Hey everyone, thanks for joining. Today we're going to talk about myocardial infarctions, otherwise known as a heart attack. Okay, so myocardial infarction. Here's our learning objectives. We're going to look at what is an MI, who's at risk for MIs. We're going to look at the nursing role when dealing with patients who have just had an MI, so we might do a little latte. We're going to look at patient education. So what do we as nurses need to tell our patients? We'll discuss a little bit about premature myocardial infarctions and those risks. We'll also look at the cost that heart attacks have on the healthcare system, some ethical circumstances that nurses might run into, and legal situations and issues that surround these patients. What is a myocardial infarction? An MI is basically when the demand of oxygen-rich blood that the heart requires is greater than the supply that the body can produce. This could be through different sorts of things such as atherosclerosis, so we're not getting enough blood supply to the heart's having to work harder. Coronary artery disease, so we're seeing those buildup of plaques inside the walls and the vessels of the heart. Emboli, so we've got a blockage. Arterial fibrillation, so our heart's not actually pumping efficiently or effectively. Systemic shock. Anemia, so we just don't even have adequate oxygen on those red blood cells. Tachyarrhythmia, we have this increase of heart rate, so our heart's just pumping, and it can't keep up. And so we end up exhausting it. And hypoxia, again, where we've got a decrease of oxygen. So all of these things can potentially cause a heart attack. Different risk factors, and you'll see a lot of these comorbidities in patients in the clinics and hospitals. A lot of them have hypertension, they have hyperlipidemia or high cholesterol levels, they're on statins or on beta blockers. Sometimes they're obese, sometimes they're not obese, sometimes they are just the skinny little girl who's got high cholesterol and high blood pressure because they love their bacon. Smoking is another real big one. This is across the board. Smoking just kind of causes all kinds of health problems. Previous myocardial infarctions, already if they have all these precursors, they've had a heart attack, at this point, their heart's already been damaged, so it's having to work harder because of that. They're at risk for another one or even another blockage in another artery that could cause another heart attack. Impaired renal function, again, this is kind of going into that effect where one system will affect another. If my kidneys aren't properly working, we can end up having high blood pressure. That causes increased work of the heart load or increased work for your heart. Stress, such as doing these PowerPoints. Just kidding. Stress can definitely impact your heart. It causes tachycardia and can, long-term stress can ultimately cause structural changes in the different chambers of your heart. A sedentary lifestyle, since your heart is a muscle, the less we're using of it, then it's not as efficient and effective, and you can end up with lower ejection fractions in that left ventricle. Things that you can't really change, race, family history, and gender. These are things like men are generally at higher risk than women for heart attacks, and Caucasian men actually are even of a higher risk. If you have a family history of cardiovascular disease or any heart attacks or hypertension, hyperlipidemia, you're already at risk for possibly having an MI. And then we're seeing a lot of patients who are substance abuse users, especially those who are polysubstance abuse. So we have these amphetamines, fentanyl, things that are increasing our heart rate and our blood pressure, and our heart just can't handle it. And the oxygen demand is not being adequately provided by the blood supply. So moving on, I guess actually before I move on, I found this cool little, it's not cool, it's actually kind of sad, uh, cardiovascular disease, but myocardial infarctions attributed to 8.9 million deaths in 2019. Most of these can be prevented with lifestyle modifications, and we just don't see that here in the world. So this kind of is a cool picture I found about the risk factors for myocardial infarctions. Basically, it took about, these are the risk factors. We've got like anemia, hypertension, hypoxia, tachycardia, all these things that they just kind of went through. And it kind of like showed like, here's your risk. This increases your risk if you only have this. But hey, what if you're sick? What if you've got this? What if you've got this? Then as we add more things, you actually just increase your risk. So impaired coronary flow, if we've got cardiovascular disease and then I've got diabetes on it and my kidneys aren't perfusing, so I've got hypertension and I got all these fats from hyperlipidemia running around in my blood. We are just adding to this blockage that we potentially can cause a heart attack through either your coronary arteries or pretty much any artery in your body. So, hyperlipidemia is actually one of the highest percentages and leading causes to people who have cardiovascular disease, but also for stroke. Or, oh my God, I'm so sorry, wrong disease, for myocardial infarctions. So premature myocardial infarction affects individuals ages 18 to 65. This is our generation. We're seeing people with substance abuse, different kind of diseases, so thrombophilia, genetic defects that can also potentially cause a heart attack, immune disease, allergic reaction, and psychological stressors. So these are a little bit different than your typical 65-year-old person who comes in for myocardial infarction. These are these younger individuals, and this is generally what's causing those. But substance abuse is huge for this population. So as a nurse, what can you expect to see? Our patients who are coming into the ER typically with these symptoms have chest pain. They come in, they're like, my chest feels like it's crushing, like it feels like there's a cage around it. There's just this pressure and heaviness, and they're going to describe this chest pain typically. Sometimes it can radiate. We can have radiation up the neck and down the arm. It can radiate to the shoulders. They might also just feel like their heart's just beating out of their chest, these heart palpitations. Often we see that it doesn't even get diagnosed, or people don't even come to the hospital because they're like, oh, it's just indigestion. I just have this gastric pain. It's nothing. I'll take some Tums. It'll go away. In fact, that actually is one of the symptoms of a heart attack. They're short of breath. They could be short of breath. They also could be sweating, kind of feeling nauseous, and just an overall feeling of not feeling well. Abdominal pain on some. You can see some fainting. Again, that they're just tired. And then sometimes they just don't feel right. There's not really any of these symptoms, but all of a sudden, get some labs and you're realizing, oh my gosh, this person has just had a heart attack. So the most important thing is if you see somebody or you're just like, they just don't seem well, get help, call the rapid, call 911, you know, don't don't ignore this chest pain that's like, oh, it's just anxiety. Because most of the time it is, but maybe it's not. So as I had said earlier, we're going to get some labs. You might not know this patient even had a heart attack. You get the labs. What's the lab we're going to see for myocardial infarction? Every time we are going to see the troponin. Um, that's the gold standard for myocardial infarction diagnostics. Um, it's not the only thing that they can go off of, but it is one because it can also be other things. But also we're going to look at an EKG or ECG and looking at if there's changes from maybe a previous one. If they don't have a previous one, we'll just kind of monitor it one, when they first get there and then one later and compare them. It can be in ST elevations, and this would cause for these NSTEMIs, which is an ST elevated myocardial infarction, or there's non-STEMIs. So basically, it's not an elevation in the ST. There's not any change there. In fact, that might look normal, but we're seeing some other arrhythmia happening. An echocardiogram is going to look at the structure and functioning of the heart. We should be seeing, they may or may not do a cardiac MRI. It's kind of depends on the providers. Nuclear stress test, guaranteed that's going to be something that a physician's going to order. So we're going to want to see how this heart does. It doesn't cause a heart attack. It's safe for that. So if your patient has that question, is the stress test gonna stress my heart out and cause a heart attack? It's completely safe. These patients also, we're going to put them on tele. And then another diagnosis that we might see is the angiograms. So kind of moving forward, we could definitely see the angiography. We're going to look at the arteries inside for, that's what this is going to do. If a stent needs to be placed, then a stent will get placed. So that kind of is in the diagnosis and part of the treatment. So initially, when you've got somebody who comes in for a heart attack, we're gonna get them on oxygen, nitro, and most likely a beta blocker, such as metoprolol, a platelet inhibition. So I've got aspirin on here, but you might, and these patients end up usually that's when they get sent home, but a lot of times it's heparin. You're going to see them on a heparin or Lovenox. And you might also see them on this P2H12 inhibitor. Surgical, so I talked about the coronary angiography. That's going to look at those arteries around the heart and make sure that there's not a blockage. There is, they're gonna clear it and put in a stent. Another is a CABG, so we might actually just open you up. I say we like I'm a surgeon, but I'm not. So open up and do a bypass graft. So that could be something. So if the artery is so occluded, they're not going to clean it. They're literally just going to take another harvest artery and go around it. There's pretty neat videos and pictures online if you want to look at exactly how CABGs work. So long-term treatment and management for these patients, we're looking at smoking cessation if they are a smoker. Medication adherence is a huge one too. Generally, these patients need to be on beta blockers. Post-MI, definitely if they've got any underlying comorbidities, making sure that they're taking those medications to prevent a future MI is huge. And then a low dose aspirin, just to kind of, make sure that their blood's not sticking and causing any blockages or, you know, DVTs or emboli. Exercise. Initially, after a heart attack, we're letting them rest, we're letting their heart recuperate. We don't actually want to get them up and moving around a whole lot because then we're increasing the oxygen demand and we're increasing the workload on the heart. And this heart has just had ischemia, so we or even necrosis in some areas. But long term, when they get home, we want to educate them to exercise. We want to educate them, to get up and get moving. Um, Diet is another big one that can definitely affect these patients. Long term, they're going to be on a low fat, low sodium diet. Again, high fiber fruits, vegetables, lean proteins, fresh foods, to limit their alcohol, and things like almonds. I mean, these are great things that we can I encourage them to add to their diets. Again, a lot of this is going to also go hand in hand. I mean, these are all good things to know, or to do, but depending on their underlying cause. So if they've got high cholesterol or hyperlipidemia, we're looking at low fats. If they don't, you're like, well, your cholesterols are great. Telling them to not eat fat really isn't treating that underlying cause. So treatment really is based on the individual comorbidities and reason for their MI. So education, I talked a little bit on this in the last slide. Encouraging exercise, 30 minutes a day, just a brisk walk maybe after meals, 150 minutes a week of moderate exercise, smoking cessation. So this is probably the worst thing you can do because it decreases that oxygen supply to the heart. It also, nicotine acts as a stimulant, increases the heart rate. So it's just all around, just a double whammy. Diet, that kind of pertains to their underlying causes, and having a healthy diet, whole grains. Almonds are great. I actually just saw a cool little research about how almonds are like a cost-effective way. If you just eat almonds every day, like a cup of almonds, it's actually cheaper than like all the other things that you would have to do for myocardial prevention. It's like, why not just eat a cup of almonds, get your belly full, and prevent your heart attack? Blood pressure, diabetes, cholesterol, and lipids. So basically controlling those. We're looking and talking to patients about their medications, seeing if they understand how to monitor their blood pressure, how to monitor if they have diabetes. Again, a lot of this is just underlying issues and comorbidities that are causing this, and helping the patient to live a healthier lifestyle that they want. And then I guess it's really important to let them know the signs and symptoms of a heart attack. Reassuring them that maybe it's not anxiety. They can come in because they have chest pain. Chest pain is not anxiety all the time. It's give me a heart attack. So financial effects of MIs. So they cost us a lot in the healthcare system. It's ridiculous. Just going off, it's just some fun facts. In 2014-15, the estimated annual cost for cardiovascular disease in just the US is $351.2 billion. The year later, in 2016, acute MIs accounted for $84.9 billion of that. So cardiovascular disease, MIs, these are huge, huge costs for the healthcare system. So again, here's that little, I talked about the almonds. Consuming 42.5 grams, 1 cup of almonds per day is a cost-effective approach to prevent cardiovascular disease. I think what it was that saved. So barriers in healthcare, looking at what are some of the things that can prevent individuals from getting treatment for a myocardial infarction or heart attack. There's a lot of time there's a stigmatism and discrimination that these patients just don't want to go and seek help. They underestimate the severity of it, and it's like, this won't happen to me, or it's not a big deal, or um, they kind of just don't want to go to the doctors, and that's a um, pretty big reason that a lot of these MIs go undiagnosed, and um, the reason there is such a high mortality rate. Lower socioeconomical status is also one of the factors that prevents people from getting care for MIs. Rural areas just aren't really equipped for patients with MIs. These high poverty areas don't have the funding for for um, a cardiac floor. You go to some of these low poverties, and there just is not the healthcare that's available to them, or the clinic that's available, or maybe they don't have the transportation to get there. There's all these barriers with lower socioeconomic status that really increases their risk of heart attack. Higher stress levels, with the burden of finances, and then you get people who smoke, and there's a rabbit hole we could run down if we had the time. But we don't. So other things that can prevent barriers. So in larger cities, you'll see things like home visits, telephone follow-ups, better like self-management enhancement, patient education and counseling. These are not always available to everybody in every place that you live. There's not home health nurses in a lot of areas in, different parts of the United States. You get into, um, like I said, rural areas, and that's just not even available for them. There's not the resources there. And the demand for care is so high, and the level of like providers and nurses is so low, that some of these follow-up appointments and follow-up telephone calls just don't even get made. There's also things like with education. I saw this great thing where a nurse had not only just provided like follow-up calls, but then she had a follow-up education book. And it was like the person, after their heart attack, went home, they worked through this workbook, and they learned about what their heart attack was. And she continued, the program basically said, we're going to continue to follow up with these individuals to make sure that they're getting the education that they need to know about their diet, about their lifestyle. And then we're checking in, we're holding accountability. This is not always the case in smaller areas where the patient load is high and the provider and nurse ratios are low. So those can be some barriers in healthcare, not just in myocardial infarctions, but in kind of the whole healthcare system. Moving on, things that this population are at risk for. We're talking about people over the age of 65. They are at risk for abuse. Basically, elder abuse because they're over 60. It can be anything from neglect, abandonment, physical and emotional abuse, financial or sexual abuse. So what we're looking for are things like, we're assessing their skin, bruising that just doesn't seem right, unexplained fractures. If these people are like super malnourished, you got to be wondering, especially if you get somebody coming in from really anywhere actually, Dehydration, that's kind of, I mean, they could just be dehydrated because they didn't drink enough, but if your little spidey senses are tingling and you're thinking something's not right, report it. Because we are mandated reporters as nurses and as medical personnel. Other things to look for, pressure ulcers. If you're not rotating your patients and they get a pressure ulcer, that's neglect. You're neglecting your responsibility to provide this patient with care. And then indications of sexual abuse. All of a sudden your patient is incontinent, never has been, or you know, there's bruising or anything like that, get those tests and talk to them. And then the financial exploitation, that's actually a little bit bigger in these populations. You see that they can get taken advantage of very easily for money. And sweet little grandma, just fell for that telephone scam and sent somebody a whole bunch of money, and now all she has is now our savings is wiped out. All right. So that just about wraps it up for us. So the myocardial infarction, let's just review real quickly some of the key points. What it is, it's a mismatch in cardiac output versus the demand. Who's at risk? People with cardiovascular disease, diabetes, hyperlipidemia, hypertension, obesity, and usually older age. So again, those underlying factors, those comorbidities. So with prevention, we're looking at lifestyle changes, we're looking at medication adherence for the underlying cause. Diagnostics, we're going to see them, our patients are coming in with that chest pain. It's like the telltale sign. If they have two of these three things, you can definitely, suspect that they're having a heart attack. So chest pain, an elevated troponin level, and an abnormal ECG. So we're recognizing, again, this is what our patients are going to look like: chest pain, sweating, nausea, shortness of breath, these heart palpitations, or maybe they just say they have indigestion. So don't ignore that person who says, oh, it's just heartburn. Maybe it's not just heartburn. Treatment and management. So initially when they come in, we've got that oxygen, aspirin, nitro, and then we're going to see them being put on some beta blockers to control hypertension, if that's their underlying cause. All right, and just the list of references. Everybody, I hope you had a good time. I hope you learned some stuff. This was fun. I'll definitely see you guys next time. Bye.